So it's pretty clear after sitting through 3 lectures this afternoon that the overwhelming theme is right care, right place, right price, right intensity, and observation is a terrific sort of lens to look at all of the healthcare issues that Carson just developed for us. Why are we all feeling so much pressure related to observation? Sherry brought up the patient's perspective. How many of us are having conversations with our hospitals regarding observation, starting a unit, running a unit, participating in a unit? How many are being asked to make a decision about whether the patient should be observation or not, which is amazing in the era of the 2 midnight rule when we are not making any of the acute care decisions 12 hours after the patient's seen. And I'll go through some of those issues. These are fairly complex topics that I've been asked to address. So I'm trying to hit the high points. And again, I'm very happy. We usually cover topics like this in a 5-day conference. I'm very happy to have added dialogue throughout the rest of today and tomorrow. So why is OBS important right now? Cost, cost, cost. That's basically it. CMS recovery audit contractors are going back to hospitals and taking back billions with a B of dollars based on, hey, we don't think this patient should have been an inpatient. We didn't want to pay you $5,000 for the DRG, the diagnostic related group payment for complex pneumonia. We think it should have been observation. Hospitals are under pressure to cut costs, and Carson actually developed some of those concepts already. You're in an ACO, you're in a Medicare shared savings project, or how many have a hospital that's directly insuring the community themselves? North Shore LIJ, St. Barnabas, Dartmouth, Geisinger, all over the country. The hospitals are taking on their own risks. You bet they care about cost. And in the end, when the cost gets less and less and the hospital gets a bundled fixed payment, that's another theme that we're repeatedly hearing. What matters? Resource use. How do we get our arms around resource use? Benchmarking and data, which is why this is all coming together. So who is the master of efficiency in the house of medicine? Is it the pathologist? Is it the radiologist in a dark room drinking some coffee, kind of getting comfortable at about 9:30, maybe 9:45 if it's rainy out? It's the ED group. We are the masters of throughput and the masters of efficiency, and that's why when hospitals are receiving a small single fixed cost, they are coming to us specifically to solve their observation problems. Let's drill down on this DRG economic process. It's not something that as outpatient docs we're frequently confronted with. Medicare pays a big fixed amount for inpatient care. Almost everything goes under, once you hit that inpatient threshold, that 2 midnights now, the hospital gets a very large single payment from Medicare, and it's called a DRG, and it's based on the patient's diagnosis. The ER diagnosis plays some role, and then usually it's the discharge diagnosis. Looking at a large amount of data, this is work done by Chris Baugh out of the Brigham, published in Health Affairs. Chris happens to be, he's a personal friend, he's the chairman of the ACEP OBS section. It is an active section, open to everybody. Average cost savings using observation appropriately, $1,572 per patient, annualizes to $3.1 billion. The recovery audit contractors last year in 2015 took back $2.7 billion from our hospitals, 62%, almost 2/3 of that money, specifically related to, it just should have been an OBS patient, not an inpatient. That simple decision, are they an inpatient or are they an OBS patient? And again, I think we all adhere to the same party line. How would I know what the second step in the syncope workup is for a 58-year-old diabetic hypertensive when the hospitalist might get a neuroconsult, but they might not? And if neurologist B is on call, when that consult comes in, then the patient absolutely gets an EEG before they go home. Well, since I can't know that, I can't control it, so we should not be the ones making that decision. It doesn't make sense. So the hospitals are now pressured to avoid these short inpatient stays, and initially it was simply a billing change. Well, make them observation. We're going to do the same stuff. They're going to be scattered, 9 west window bed, 4 green in the back, 16 doors away from the nursing station. It was just a billing change. Now that it's stuck, and it's been with us for years, because observation medicine was popular 10 or 15 years ago as well. It's got a resurgence because now 1/3 of the hospital admissions in some places, 40% in others, are now being deemed observation. And with that single, smaller bundled payment, throughput is what's important. Just like it's important in the ED, it's even more important, throughput and resource use in the OBS unit. And again, we are the masters. So what I usually do is try and give a little sketch of the landscape. Now let's drill down on what are the codes and what are the payments and how do we get there and make it work so we have the resources that are dependent on that revenue. So there are requirements by both CPT and Medicare. Observation care is a well-defined set of specifically clinically appropriate services. In the end, a decision is being made regarding whether the patient will require further treatment as an inpatient. So it used to be and this was very confusing to all of us when we first started to focus on OBS. What are we observing you for? Well, if you have a head injury and we're observing you with serial neuro exams to see if you're getting worse, I understand that as observation. What if you're a pyelo patient who's vomiting with a temp of 101 and a white count of 60? What am I observing you for? I know exactly what you have. I'm trying to get you better. Here's the primary document, if anybody wants it, CMS Transmittal 1745. And what I'm just trying to do is to lay the groundwork for the actual requirements. Such services are covered only when provided by order of a physician, and they require periodic reassessments. And that's out of the CPT book in 2016. It's page 17. So we put those all together, all of those primary source directives from both CPT and Medicare, and this is what's required for an observation record. You need a time-dated order to place an observation status, a little treatment plan. Treatment plan makes sense because it gives all of us, it forces us to have clarity. Low-risk chest pain patient, awaiting first set of enzymes, planned treadmill test. Very short treatment plan is fine. Clinically appropriate progress notes based on that CPT directive of periodic monitoring. And I usually get the question, well, how many progress notes? Clinically appropriate, totally up to us at the bedside, in the eye of the beholder. A 2-year-old with croup requires pretty frequent reassessments, and that 52-year-old low-risk chest pain patient, you're just sort of waiting for the data to come back to act on it. So very significant differences. And then something none of us have done since we were interns, a discharge summary. 1 or 2 sentences. Troponin negative, treadmill test normal, patient without symptoms, plan home follow-up to monitor blood pressure. Fine. Quick discharge summary. Very easy. The codes. The codes are a little confusing, so I'm going to slow down here. Observation care sometimes takes place all on one day, all on Monday, and sometimes the patient comes in Monday and they leave Tuesday, and there are different codes, different RVUs, and different monetary values. Care all on one day. Patient comes in 8 a.m. on Monday, leaves 8 p.m. all on Monday. Low, medium, and high severity. 992, 34, 35, and 36. Those are the CPT codes. Quick note, Medicare requires 8 hours of observation, and most of the private payers are going in that direction, and the facility needs 8 hours in order to be paid as well. What if the care spans 2 days? The patient comes in Monday at 3 p.m. and leaves Tuesday at 10 a.m. There are codes for day number 1, low, medium, and high severity, 992, 18, 19, and 20. And then a discharge code for Tuesday morning. You round Tuesday morning, you look at that troponin, the treadmill test is back, and the patient goes home. There's some specific requirements. They're detailed right in the CPT book. Follow-up instructions, documentation, and a little physical exam. So let's put that together. Low, medium, or high severity. All the care is on Monday, 992, 34, 35, and 36. Or patient comes in Monday and they leave Tuesday. On Monday, low, medium, and high severity. And on Tuesday, you grab the discharge code 99217. How about the RVUs? After all, I'm a billing guy, so eventually I have to get down to RVUs. So 99285 is a good benchmark, 4.90 RVUs. Most EDs now, if they're involved with OBS, see higher complexity OBS patients. So let's take a look at 99236. The patient comes and goes all on Monday, 8 a.m. to 8 p.m., 6.13 RVUs compared to 4.90 RVUs. About $50 on the Medicare fee schedule, $50. Or the patient's care spans 2 days. You grab your 99220, 5.22 RVUs for Monday. Tuesday morning you round, write your little discharge note, 2.05 RVUs. The total now we're up to 7.27 RVUs for that patient instead of 4.90. How do we determine that low, medium, and high severity? And by way of background, usually we get some direction from the carriers. There's sort of an institutional culture of audit experience. There are published documents, or even in the back of the CPT manual, there are clinical examples. The CPT manual is published each year. The appendix that has the examples is Appendix C. And you can look up actually what the CPT committee used to value our codes. You can even look up 99284 and see what it looks like. Unfortunately, the observation codes are new, and they do not have developed Appendix C examples. So most ED-run OBS units, I think I already mentioned, see higher acuity patients, chest pain, TIA, syncope. How many have not dehydrated gastroenteritis in their OBS unit? Not too many folks. And our E&M distribution, that selection of the low, medium, and high severity, will be influenced by that predetermined acuity. So I mentioned there are no vignettes and no clear carrier direction that's published related to how we score these cases. But the Relative Value Update Committee was forced to develop some vignettes for the codes when the RVUs were assigned. So here are the vignettes. They're not in the public purview, but they're not necessarily required to be behind closed doors and under seal. 99234. 19-year-old pregnant patient, 9 weeks gestation, presents to the ED, vomiting for 2 days. Patient is admitted for OBS, discharged later on the same day. So in my emergency department, and most of the groups that we work with, this patient gets a second dose of Zofran and some IV fluids. They are not placed in observation. 99235, 48-year-old presents with an asthma exacerbation in moderate distress. Oh, first round of the nebs are not better. Let's get them upstairs. Absolutely not. Some of these patients end up in our OBS unit. And here's the common one. 52-year-old comes to the ED because of chest pain. Chest pain is the most common presenting complaint that ends up in ED-run OBS units. Medicare doesn't quite publish, but if you get their gigantic clunky database, you can distill down the E&M distribution, the low, medium, and high severity, the assignment of that 992, 34, 35, and 36 for the specialty of emergency medicine. We analyze those. 10.9% 99234. Pregnant, 9-week gestation, vomiting. 27.3% 99235, moderate asthma exacerbation. 61.8% 99236, TIA, syncope, low-risk chest pain. This is a good benchmark to start looking at your OBS E&M distribution if you haven't done so already. So the hospital wants a lot of awareness and thought going into OBS. So who should be in OBS? How many feel like they're pressured to put people in OBS that they really don't think are appropriate? Yeah. So let's change that. Which OBS patients will an ED group be successful with? And what's success? I want to be a value-added partner to my hospital. So if I'm going to run an OBS unit, I want to be able to deliver a shorter length of stay than if that patient is in a scattered bed, 9 west window bed, 16 doors from the nursing station, by using dedicated staff and focused protocols and good patient selection. So I want to be able to achieve expedited throughput. We're going to create hospital value by decreasing our length of stay because the hospital receives a single fixed payment for OBS. And if they're in the unit for 40 hours, the hospital loses money. The break-even point is probably about 20 hours. And if I do it in 15 hours, the hospital makes money. We want to reach a successful clinical endpoint. After all, I recognize it's late in the afternoon and there's a guy in a dark suit and I'm a self-professed billing guy, but it's all about the patient. We all went into this, actually. The no money, no mission is driven by the mission, not the money. We need to create patient value. That means we need to get to a good, successful endpoint in our care, not, well, the second troponin was negative, we're not doing a stress test, and then the patient represents to the emergency department a week later, we're back in the same place. And prolonged lengths of stay, and that's sort of key for the throughput benchmarking folks here, absolutely drag down RVU efficiency, and we'll look at an example. So on the left side are the more common presentations that we will be successful with. Successful in reaching a good endpoint for the patient, successful in decreasing length of stay. Chest pain, abdominal pain, headache, pyelo, asthma, renal colic, allergic reaction, bad pharyngitis. On the right side, a little bit harder. Closed head injury, vertigo, hematuria. Those diags here on the right are harder because of two things. They have multiple clinical branching points, which makes it harder to standardize their protocols, and they're very resource use intensive without firm endpoints. Let's go all the way down here. Back pain, non-ambulatory. 82-year-old female, creatinine 2.3, UTI, dehydrated, slips, falls, non-displaced coccyx fracture. Nobody will admit the patient it's a social, put them in your OBS unit. How do I know when I'm done? Can I transition that patient to a skilled nursing facility from my OBS unit? Unfortunately, no. Unfortunately, no. Extremes of age, mental health, and people needing significant IV pain medicines usually are not good OBS candidates. Let's look at some examples here. Length of stay and cost improvement. Can we really bring hospital value? I picked just one study. I could have literally shared 5. Tough cohort of patients, published in Annals, 5 different EDs, good N of 124, greater than 50-year-old patients with syncope, published by Sun. Length of stay, inpatient 47 hours, placed in a CDU 29 hours. We created huge value for the patient and the hospital. Cost, $2,420 inpatient, CDU, $1,400. Big cost savings. Question?
To clarify, but the difference between those is the inpatient is run by inpatient service versus the CDU being run by emergency physician?
Yeah, the question is, in the Sun study, is the difference that the inpatient is run by, let's say, hospitalists or maybe even just the primary care physicians, and we're talking about an ED-run CDU, a tightly run OBS unit. Yes, excellent, excellent point. Large multi-site group data, this is a group we're currently working with, 8 complaint-specific protocols, big, busy 70,000 visit ED. So the hospital said, okay, we want you to start an OBS unit. We said, okay, let's figure out who's going to be in the unit. And Mr. CFO, you need to show me your DRG data for the average length of stay for TIA, syncope, COPD, simple pneumonia, and chest pain. I want to create a baseline because I'm going to work really hard to bring value both to the hospital and the patient. Let's get a baseline. Average length of stay inpatient, 38 hours. Not rocket science. Good protocols, good patient selection. OBS length of stay down to 19 hours, literally exactly in half. Treated 3,500 patients the first year, times the 19 hours of length of stay. Cost savings, 66,500 hour decrease in length of stay. Big hospital resource cost savings, consistent with sort of the bigger mission. Here's a vignette that demonstrates who we want and who we don't want in an OBS unit. And again, it's not that we're being selective or selfish. It's the goal is for the OBS unit to be successful. Success defined as short length of stay, creating hospital value, and a good endpoint for the patient. CHF, 3-day stay, patient's got significant hypertension, creatinine's 2.3, blood sugar's 385. Monday late in the day, they're placed in the CDU. Tuesday, they're finally diuresing, blood sugar's abnormal. Now the potassium is overshot, totally dropped. They're spiking their blood pressure. They're finally settled out and home late Wednesday. Okay? Or alternative bed use. And it's all about throughput. Chest pain patient, 15-hour length of stay, and that's long in some OBS units. That patient goes home the same day, and in the evening, a pyelo patient goes in. Pyelo patient stays overnight, gets tanked up, gets a second dose of antibiotics in the morning, goes home. Day 3, we still got another 15 hours, chest pain patient in and out. Let's look at the RVUs. Here we have the CHF patient, day 1. Here's the CHF patient, day 2, 2.05 RVUs. Here's the CHF patient, day 3, another 2.05 RVUs. We've done all this work for the CHF patient and generated 9.32 RVUs. Now let's look at the alternative use of that bed, where we've optimized throughput. 6.13 RVUs for the chest pain patient, 7.27 RVUs for the pyelo patient. That's our 99220 for day 1 and the 99217 discharge code. And we still have time to treat another chest pain patient for a total of 19.53 RVUs. $333 or $699.72. So throughput, the mantra here that throughput matters, throughput really matters because all of these patients got care in that same bed. OBS is sometimes hard to figure out how to staff. We know it makes sense for the hospital The question is, how do we make it not hurt the P&L for the physician side? It's a challenge. That's the short answer. I feel very passionately that it brings hospital value. I feel great that if we select the right patients, we'll get to a firm endpoint and the patients will benefit. The question is, will it hurt our group economically? 10-bed unit turned 1.3 times a day, blend of moderate and high. So some 99235, some 99236, a little bit of moderate asthma, and a couple of extra helpings of chest pain. 5.5 RVUs per case, 74 RVUs per day. To make the math easy, I used a conversion factor of $34, which is very common in this room. $2,400 generated. Miraculously, that's $100 an hour. So anybody here working for $100 an hour in their OBS unit? Very tough to cover that. So what do? Physician coverage in the morning and the evening where patients are coming and going. PA and NP for interim coverage. And maybe the ED doc in the emergency department responds PRN at night for issues. I usually get a question about what's the minimum volume for an OBS unit to stand alone. It's about a 35,000 visit ED. You take a 36,000 visit ED, you're seeing 100 patients a day, 21 admissions. The typical metric is if you have a robust set of protocols, about a third of those admissions, probably be on the lower side when you first get started, would end up as OBS. That's 5 to 7 OBS patients. You start with chest pain. Everybody starts with chest pain. It makes sense. Firm endpoint, easy to administer. And then you creep up. Dehydration, pyelo, asthma, based on your local patient population. Staying away from the things on the right side, like hematuria and bad vertigo and chronic pancreatitis, and moving towards the things that were on the left side of the slide, the TIA, syncope, COPD. Big changes regarding the way the facility is reimbursed, and it's a perfect lens into the theme that we've heard throughout the day. The facility is now getting a single payment for OBS, and it includes everything. It includes labs, CAT scans, ultrasounds, hydration, injections, infusions, medications, little procedures. So then what happens is everybody cares a lot about resource use. Here's sort of the regulatory process underlying it. Last year, Medicare created a concept called Comprehensive APCs. What they're trying to do is to take the outpatient world and make it like the inpatient world, where there's a single cost for the service, they can budget for it, and they figure, well, if we're going to pay the hospital $2,000, no matter what they do, eventually they'll figure out how to be a little bit more efficient, which will start with benchmarking, resource use, and quality. Comprehensive APC includes all adjunctive services provided to support the delivery of the primary service. And here's the outpatient prospective payment system final rule reference, if anybody wants it. Now bundles everything, except for they list out a couple of very specific things that aren't taking place in any of the OBS units that we're working with. Corneal tissue transfer, if that was taking place in your OBS unit, will be separately paid, thank goodness. Vaccines, mammography, and brachytherapy, because we're doing a lot of brachytherapy in OBS. No payment for labs, ancillaries, radiology, procedures, hydration, injection, infusion. So the good news is the hospital revenue skyrocketed with all of this bundling. And it's really, OBS is a perfect lens into this theme of how do you find a lower cost setting and then bundle everything together for a single payment. So if we go all the way back to 2010, $705 was the payment for an OBS patient by Medicare. And then a little bit of bundling crept in, and we went up to $1,199. Now this year, starting January 1st of 2016, OBS is a comprehensive APC, and the payment is $2,174.14. So really big increase, but it bundles everything. So something to be aware of. And for those who have been plagued by OBS, and it would be interesting to hear Carson's perspective, hospitals are looking at that increase not as opportunity, but they're thinking, oh, I don't know, I really liked it when I got paid for all of my ancillaries. Maybe OBS isn't as appetizing. So I've heard that from a few hospital CFOs as well. OBS will absolutely be expanding. Documentation and correct coding drive that level selection. We see a little bit of moderate complexity and mostly high complexity OBS. Focused patient selection, so we bring value to the hospital. We reach a firm, safe clinical endpoint for our patients, and We have nice length of stay that creates RVU efficiency on the physician side as well. Packaging will lead to resource use pressure and efficiency pressure, what this group is all about. I know this conference has been going on for a long time, and I feel very privileged to be part of it. This is your day. The focus on resource use, bundling, and packaging will only increase. The mission that each one of you is going through at your local hospital will be the mission for the next 5 to 7 years of payment. And the ED throughput culture, we are the masters of throughput.